So, again, thank Yom for this opportunity to discuss something about the future therapies and biologics and gene therapies, my financial interests. This is something which I saw in one of the MIT Review Technology journal, which talks about creating the baby you want, about how you want to have a baby with different features. It's so exciting that the work done by Professor Sangwan in India has demonstrated his 3D corneas, and which is inspiring to a lot of us to look into that aspect of creating something for the future. The most important thing when I start off with this talk is not about perfection in skill, but it's the changing the mindset of thinking about everything. There's a lot of dogma related to many pathways, many things, but that is something we have to do. For that, what's the most exciting part of this session from everybody here is everybody is talking about new pathways, including this talk you gave about how you look at drugs, how you look at HP Gore, which we never look at it. We just look at as in some liquid in the bottle. The cardinal signs of inflammation with tumor calor and loss of functions now has to be relooked at with the same pathway mindset that you can have a white eye and still have inflammation. You can have nothing which is significant, which has nothing of this, and we can trigger this change. The role of therapeutics becomes very important because, like Professor Sangwan sir mentioned, there's tremendous amount of changes happening in your ocular surface. They're driven by your nociceptive channels, they're driven by your inflammatory channels, they're driven by multiple things for which you need to have a different mindset to look into that. The tacrolimus and cyclosporin, like Sir mentioned, works inside the cell. I made a nice cartoon about how much we don't know when you talk about a drug. There is an IKB which holds the NF-kappa B, which Sir mentioned. This is one of the drug which is in the nucleus. Cyclosporin works in the cytoplasm and then goes to the nucleus. So this holds him like a jail warden. The minute this inflammation blocks this, the NF-kappa B becomes an adult, gets into the nucleus and starts a chain of events. Cyclosporin blocks that. And it also makes the IKB to increase so that the warden becomes more stronger. The lifitegrast, it doesn't get into the nucleus. It only works on the surface because it has a T cell which has an LFA receptors and ICAM1. It just blocks the handshakes between them. So lifitegrast works more acutely on a T cell, and the cyclosporin works little later, chronically. The autophagy is very important because it changes the way the cells function. It changes the way the inflammation is. It's a lubricant, but works like an immunomodulator. This is a paper we published, and you can see the biomarkers being changed. And even though it's a lubricant, it works on many pathways of how it works. This is a video I had shown you. When you create a desiccation stress, this cell has to be eaten by this cell for the inflammation to reduce. When you have an autophagy dysfunction, there are a lot of cells which are not able to digest. And when you put a trehalose, it increases the lysozymes. It increases cells to function. This is the same epithelial cells with and without treatment, and just shows the impact of how it works on the inflammation. And you can see the changes out here. I have shown this two things, and what is important is trehalose also changes the nociceptive factors. So the modern day lubricants works not just as a lubricant, it also works to improve the nociception also. So how do you take the more ideas? Curcumin, which we gave as orally, has tremendous potential in blocking the NF-kappa B, this exact pathway which cyclosporin also changes. And in one of the talks, we mentioned about central sensitization. For the pain to become central sensitization, you need to block these pathways. There is a role of resveratrol. This is the wine. But to get the same effect on the eye, you have to drink 800 glasses of wine to get metabolites to reach it, which is humanly impossible, I assume. But it also has a huge role, not as an inflammation, but also to reduce the brain becoming active. Because there are two things. The brain is not involved in the first initial part of the ocular pain, and the brain suddenly becomes very active, which becomes central sensitization. Two things which works very well orally, which is something called as a maladaptive plasticity. To reduce it is, one is omega-3 orally, and the second one is resveratrol and curcumin. And the curcumin, resveratrol orally also dampens the chronic nociceptive pain without stain. And this paper says that the chronic firing from your response gets, so when you have a patients who complain of chronic pain without stain, there is a role of resveratrol in this, because it can do things. One is in the brain, and also it also has an impact on the ion channels. So huge role of interest in gut dysbiosis, which has been discussed. And this is one of my patients who had very bad gut dysbiosis, and look at the amount of T cells in your cornea. Just shows the power of how much we need to take care of the gut in our process. The second part of my talk is all about the role of gene therapy and how it has an impact in ocular surface disease. If you look at this, 8% of DNA comes from your virus. So we are actually not just directly linked to apes, we are also linked to virus. Lot of us evolutionarily, lot of those virus has got into our DNA, and they are all there. And if you look at it, it has bacteria. We are not just direct descendants from apes or even before that, and it has mix of all kinds of stuff. So what we are trying to do is, can we create changes like how the CRISPR revolution happened in gene therapy? There are different types of gene therapies. You have something called gene addition. A healthy gene is replaced. Gene inhibition, you slice the gene off. Gene correction, that means you have to have the CRISPR. It's just an enzyme with Cas9 to change it. And there is a very new exciting role of CAR-T, which is immune-based gene therapy, where you change the T receptors. That's exactly one of the things what got the Nobel Prize for this physiology and medicine this year. So what we did in our work is, we started looking at keratoconus, because we started looking, the best place to start look at a gene therapy is on the cornea, because of its avascular status and its ability to work better. And we worked on multiple genes, of which lysyl oxidase, TGF-beta1 pathways, multiple genes were found, but they were all scattered. And each of these genes has a particular role in what it does. Then first thing we did is to look at the genes of the bacteria in the keratoconus, and this got published, very important paper. The bacterial genome in keratoconus is completely different from the bacterial genome of a non-keratoconic eyes. That means this paper suggests that there is a huge role of bacteria driving keratoconus, because these bacteria, I can't pronounce most of it, but Cutibacterium secretes IL-2s. There's a mycobacterium secretes something. There's a flumic thermocytes. They all secrete different types of secretory pathways, which could make you rub your eyes, or could probably change the way the milieu is. So I'm optimistic that one day we'll say that bacteria drives keratoconus. It's a bacterial infection. And that's why I said these are not bacteria what you culture, because only 10% of ocular surface bacteria can be cultured. 80% or 95% cannot be cultured. We took the genes of the bacteria to understand what genes are there, and looked at the genes which is there, which is already published. That's why we were able to do this study. This particular case opened up a complete new dimension into understanding the genetics of keratoconus. We had done this case. I preserve all my lenticules because I use it for studies. So I had preserved this lenticule in 2014. This patient developed an ectasia, and it was a complete normal topography. And when we found, I removed that lenticule after 4 years. Like my friends from Egypt will know that it's like mummification. I removed the mummy and we found a new gene. And that gene is called lysyl oxidase because this gene makes your cornea collagen to slip. This is the one which holds the collagen. It's like the rubber band which holds your file. And we published a lot of data on this. It also says that higher level of locks is needed for good cross-linking. And again, we thought, why not look at this? Because when you do cross-linking, you artificially create a scar there. But what if you do a gene therapy to improve the lysyl oxidase itself? And because we know that if you improve the lysyl oxidase, you improve the whole disease itself. So that started our whole quest for looking at genetics and gene therapy in our practice. And this is the work using adenoviral vectors, how you can go in, use the right gene. But here we don't need to look at the gene. We don't need to look at whether the person has a defective gene or not, because our advantage here is it's a gene augmentation procedure, not replacing it. That means I don't need to bother much about the gene. And then how it changes here. So what we did was, this is a place I work. We are having a meeting in Bangalore in January 29th to 30th. I'll send the invite. You can go to this lab and see how you create. It's one of the world's first gene centers for keratoconus work. And this is initially we did a gene on a matrix. It worked very well. Then we thought, let's try it. And we were looking whether to inject into the eye or use a topical drops. Topical drops would be challenging because sometimes it just doesn't get absorbed. So what we thought, we created intact-like channels and started injecting into rabbit and mouse models. And what we found was just with one drop into the cornea, you could see the collagen becoming naturally cross-linked, not collagen cross-linked, not the scarring. It just becomes tight, wound, and it starts producing more and more collagen. And this is my colleague, Dr. Pooja. This is a cadaveric eye. We will start the first gene therapy that will be the first in the world in this, probably this year or early next year. And she makes a pocket. In this, we made a pocket. Now we have an intact incision. And this is the gene in our hand now. This is injecting the vectors. And you see the change out here. Non-injected versus injected. And you can see the greens are lysyl oxidase out there. And you can see the amount of change. And we did the atomic force. You took those rabbit's eye and see the changes, and you can see that it's a huge difference in when you inject it. So what are we doing now? When you start the human trial, we just got approval for it. Create an intact tunnels, inject into this, leave it. Immediately the genes percolates, and once it percolates, it starts making the collagen synthesis like how you're born with. The advantage, what we see is this will open a complete new dimension for many gene therapies like collagen, corneal scarring. You can use Decorin, you can use multiple things. This is just a tip of an iceberg to how you can create a genetic gene therapy into the practice. So to sum up, there are therapeutics. I'm done. We can off it. And there are therapeutics and there are gene therapies, two extremes, but both are practical. And hopefully next year, if I'm called here, if I'm here, then we'll have the human trials of these patients. Thank you.